Hello everyone, and I hope everybody is doing perfectly fine. So today the topic of our discussion is a rare case, and I'll discuss two cases related to this and how we approach to the diagnosis, and also few words about these two entities, that is hemophagocytic lymphohistiocytosis and scrub typhus. So this HLH, so as we commonly hear about it, hemophagocytic lymphohistiocytosis, or also known as HPS, that is hemophagocytic syndrome. It's a rare hematological phenomena, and how it occurs, it results from your prolonged and excessive activation of antigen presenting cells and the CD8 T cells. So they have a role. APC, that is activation of antigen presenting cells, and CD8 positive T cells. So it can be your inherited also. This HPS, that is hemophagocytic syndrome, can be inherited, as well as it can occur secondarily to different kind of infection, malignancy, and it can occur at any age. And diagnosis is established by the proposed HLH diagnostic criteria. So we have certain diagnostic criteria, so which has to be sufficed to arrive at a diagnosis of HLH or HPS. Now we are studying this HLH in association with scrub typhus. So few words about scrub typhus. It's an infection and important etiology of acute undifferentiated fever in our country. It is basically a rickettsial illness which is caused by its organism Oriental Sushu gamusi, and this is transmitted by the bite of the trombiculid mite. So how the patient presents with? Patient will have flu-like symptoms like fever, headache, myalgia, which may last for a period of more than a week. And in some cases, it can turn out to be fatal by resulting or culminating in multi-organ dysfunction and eventually causing death in certain cases. So this is the diagnostic criteria, which is very important to remember. So HLH, so it can be diagnosed if, first point is very important, even if there is a mutation in known HLH associated gene, so that is diagnosed as HLH, and alarm. So one diagnosis is the genetic. So if you get a mutation in the known HLH gene, so that is confirmed that patient is having HLH or HPS. And apart from that, so we have your 8 diagnostic criteria, और इनमें से अगर 5 भी positive होते हैं, so patient present with any of the 5 of 8 diagnostic criteria, so we label it as HLH or HPS. So what are the different criteria which we have to remember is fever. If the patient is having fever, peak fever more than 38.5 degrees Celsius, which is for more than 7 days. Patient presents with splenomegaly, spleen palpable more than 3 centimeter below the costal margin. Then third criteria which is important is cytopenia involving more than 2 cell lines like hemoglobin less than 9, absolute neutrophil count less than 10 per microliter, then platelet less than 1 lakh per microliter. So all these more than 2 cell lines need to be affected. Then fourth point is hypertriglyceridemia, that is fasting TG levels should be more than 177 or more than 3 standard deviation, or hypofibrinogenemia, that is less fibrinogen levels, that is less than 150 milligram per deciliter. Hemophagocytosis presence in biopsied samples, maybe bone marrow, spleen or lymph node. I'll show you the images of bone marrow aspiration and biopsy, which we found positive for hemophagocytosis in both our cases. Then low or absent natural killer cell activity, serum ferritin more than this, serum ferritinemia. Ferritin levels would be more than 500 nanogram per ml. Then last criteria is elevated soluble interleukin 2, that is CD25 levels, more than 2400 unit per ml or very high for age. So these are the 8 criteria of which अगर 5 भी positive आते हैं तो हम patient को label कर सकते हैं as hemophagocytic lymphohistiocytosis or hemophagocytic syndrome. Now I'll discuss 2 cases with you related to HLH in patient who had scrub typhus. So first case is a pediatric patient, 10-year-old male child, presented to Peds department with complaints of fever and decreased urinary output for last 5 days. Fever was intermittent in grade, 102 degree Fahrenheit. It was continuous and relieved on medications, on supportive management. Patient had 3 episodes of non-projectile vomiting. However, there was no other significant history of illness in the child. Examination, what we saw, patient had pallor and puffiness of face. There was no palpable peripheral lymphadenopathy. Per abdominal examination, there was hepatomegaly, 4 centimeter below costal margin. However, there was no splenomegaly seen. History when we took for the lab investigation, so complete blood count revealed decreased hemoglobin, TLC was okay, platelet was reduced, RBC was reduced, hematocrit reduced, all the red cell indices were reduced, and reticulocyte count was 2%. Peripheral smear revealed predominantly normocytic normochromic RBCs with presence of few microcytes. WBC showed relative neutrophilic prominence, however no toxic granules or any hemoparasites were seen. Platelets however were reduced on smear. LFT patient, it was like SGOT, SGPT, total protein, bilirubin, those were all within normal limits. LDH was however raised. KFT was deranged. Urea and creat was raised. Urine examination revealed pus and RBC in the routine urine examination. Patient underwent 1 dialysis after 1 day of admission in the hospital. Patient had serum ferritin levels increased. TG levels increased. Blood for HIV and HIV2, these all were negative. The viral markers were, they were seronegative. And then patient was moved ahead for rickettsial OX19 titer, which was positive. USG abdomen showed hepatomegaly with fine collection of free fluid. CECT showed few subcentimetric non-necrotic lymph node in the mesentery. Patient was subjected for bone marrow aspiration. And when bone marrow aspiration was done, it was found to be cellular, showing many scattered histiocytes, significant number of hemophagocytosis. So in view of the clinical profile, the detailed clinical profile, lab parameters, peripheral smear finding, bone marrow aspiration finding, a diagnosis of hemophagocytic lymphohistiocytosis was considered, and this the patient of scrub typhus, because the titer of the seropositivity was also seen for scrub typhus. So see, this is the bone marrow aspiration image, a very cellular aspirate. Here we can see there is increased in erythroid. See, erythroid lineage. So erythroid hyperplasia is there with scattered myeloid elements are there, sorry. And this is a big megakaryocytes you can see. And here what you're seeing is small cell erythroid cells which is coming inside the megakaryocytes. So there is evidence of hemophagocytosis. So here you can see this is the smaller image of the previous one which I showed you. So this is evidence of hemophagocytosis. This is a bone marrow biopsy section. Here you can see cellular marrow hai ye, with all the elements. This is also same with scattered hemophagocytosis. This is a larger view of the, I wanted to show you that how hemophagocytosis, intact cells are coming inside. Then coming to case 2, that was a pediatric patient. Then here 36-year-old male who presented with high grade fever, and patient had pruritic macular rash on the abdomen which had developed on 3rd day of fever. Patient had difficulty in breathing, swelling over the limbs and yellowish discoloration of the whole body. So there was no history of chronic illness. CBC, it was found hemoglobin is less, then platelet was reduced on smear. Peripheral smear showed normocytic, predominantly normocytic normochromic RBC with mild shift to left and platelets with adequate on smear. USGP, it was hepatosplenomegaly with grade 2 fatty liver. 2D echo showed mild pericardial effusion with left ventricular ejection fraction of 60%. LFT was deranged in this patient. Triglycerides were deranged. Decreased levels of HDL was seen. KFT, there KFT was deranged, here our LFT is deranged. Serum ferritin दोनों में बढ़ा हुआ है. It was markedly raised here. LDH also increased. Persistent hyponatremia was seen with hypoalbuminemia and decreased levels of fibrinogen. So all fitting into the criteria of HLH. Rickettsial serology here also was done, and then it was also found to be positive. So this, both the cases of scrub typhus is presenting to you with evidence of hemophagocytic lymphohistiocytosis. All the seronegative markers, viral markers for that patient was negative. Urine and blood culture did not show any bacterial growth in our second patient. Bone marrow aspiration, similar finding. It was cellular and showed erythroid hyperplasia like our previous case. Erythroid series cells were predominantly normoblastic, few megaloblast, and dyserythropoiesis. Evidence of dyserythropoiesis was also seen. Myeloid series cells were in all stages of maturation. Prominence of plasma cells was seen. Scattered histiocytes were seen with occasional histiocytes showing hemophagocytosis. Bone marrow biopsy was in concordance with bone marrow aspirate finding. So there was evidence of hemophagocytosis on biopsy and aspirate as well. So our patient fulfilled the essential diagnostic criteria for HLH, that is fever, splenomegaly, cytopenia, hepatitis along with hyperferritinemia, hypertriglyceridemia. Hemophagocytosis was seen on bone marrow aspiration. So that was both because secondary to rickettsial infection. In both the cases, the rickettsial serology was found to be positive. So this is the same few more bone marrow aspirate picture. This is a cellular marrow you can see, and we can prominence of erythroid series cells are very much appreciable in this smear. Here you just this is a picture to show you the different stages of myeloid maturations were there. So few point about HPS, that is hemophagocytosis syndrome or hemophagocytic lymphohistiocytosis. So it's a rare hematological disorder. So how patient will present to you: febrile illness, cytopenia, lymphadenopathy, hepatosplenomegaly, hyperferritinemia. So these are the hallmark. Phagocytosis of blood cells in the precursor is a hallmark of your HPS, achieved mostly by monocytes and macrophages. And there is one test, that is nitroglycerin reduction by monocytes is 6 times that of controlled monocyte. So that is a test of stain which we do it. So what happens here? So there is excessive activation of monocytes in HLH, which may be due to stimulation of your high levels of activating cytokines. So high levels of interferon, soluble interleukin 2 receptor, tumor necrosis factor, interleukin 1, interleukin 6, they have been demonstrated to be involved in HPS. And there is elaboration of activation of cytokines by the T helper cells. And this entity can also result from your poorly regulated or inappropriate Th1 response to intracellular pathogens. So detail of immunological protective mechanism against rickettsial infections, these are not fully understood, but macrophages and T cells, they play an important role in protection of us from your rickettsial infection and appearance of HPS. So many virus etiologies are there which can cause your HPS, like your cytomegalovirus, Epstein-Barr virus, HHV6 virus, or also can be seen in malignancy like T cell lymphoma and collagen vascular disease. So phagocytosis causing pancytopenia, this is a medical emergency and needs an aggressive treatment. So in association with scrub typhus. So scrub typhus जो हमने पढ़ा है, that is usually endemic in your Southeast Asia, Northern Australia, Pacific Island. In India, cases have been reported from Himalayan region, Haryana and South India. Scrub typhus has frequently been reported from Northeast India also with major clinical complication. So patient will present to you with febrile illness, which will result from your bite of infected larval form of mite, and this is known as chigger in endemic areas. So this has an incubation period of 7 to 10, following which patient will present to you with pyrexia, skin rash, myalgia, GI disturbances and lymphadenopathy will start. The most pathognomonic sign of scrub typhus is a ischar that develop at the site of mite bite. So during human infection, the oriental Sushugamusi, जो rickettsial organism है, that selectively it targets your vascular endothelial cells of small to medium sized vessel. However, it can also invade our muscle cells, perivascular macrophages and monocytes. So there is widespread vasculitis or perivasculitis, which is a hallmark of pathophysiologic mechanism if the patient lands up in your multi-organ dysfunction in patients with severe infection. So our patient was diagnosed to have scrub typhus. Both patients were positive for immunochromatographic card test and they were detected with IgM antibodies to oriental Sushugamushi. So clinical profile of and along with serological evidence in our patient, both were positive for scrub typhus, and evidence of hemophagocytosis on bone marrow aspirate and biopsy made us to make the final diagnosis of hemophagocytosis, which was associated with scrub typhus infection. And response, patient very well responded to anti-Sushugamushi medications, so that confirmed our diagnosis. And pancytopenia associated with scrub typhus, this has rarely been reported in literature, and in this case, both the cases have already been published. So the initial clinical symptoms of the scrub typhus are non-specific. So these are patients presented to physician with normal complaint of fever of unknown origin. And this primary HLH, so this was secondary HLH when it occurs in association with underlying any other infection. Where secondary HLH, so underlying disease that I have told, primary HLH has a genetic etiology. So very few cases of HLH associated with scrub typhus have been reported in adult, and similar reports of children are very rare. So we are discussing HLH case in one in adult male and one in pediatric patient. So few studies they have published that secondary HLH rickettsial infection की वजह से pediatric population में भी हुई है. So data are there. So they also had the similar finding, febrile illness, hepatosplenomegaly with or without regional lymphadenopathy. And this ischia, which was very pathognomonic of scrub typhus, it was seen in 50% of patients. And they had severe complication like acute renal failure and multi-organ disease. So these all findings were consistent with our patient. तो serological diagnosis जो होती है, जो हमारे उसमें antibody IgM antibody आया है for Sushugamushi, so that is possible after 5 to 10 days following onset of infection. So that has a poor sensitivity, and this serological diagnosis is confirmatory. So there is a one test also, Weil-Felix test for rickettsial infection, but that has poor sensitivity and specificity. So what we did, this IgM ELISA, IgM capture ELISA technique, to confirm in both our patients, they have shown to be better predictive value as the diagnostic test. So this HPS, though it is rare, you have to consider it in severe cases of scrub typhus, especially if the patient of scrub typhus is presenting to you with cytopenia, liver dysfunction, coagulation abnormality, and also you have to look whether this infection is occurring in endemic area also. So because that has a strong association. So a diagnosis of primary HPA should always be excluded in these cases by appropriate mutation analysis. So that HLH mutation, mutant gene has to be tested. So it is always beneficial to start the anti-rickettsial treatment empirically in patient where diagnostic facilities are not available to prevent any further complication. So to conclude, so this HLH should be considered in severe cases of rickettsial disease, especially when you have other derangements like pancytopenia and other lab parameters are deranged. The patient with scrub typhus, they have an excellent response to treatment when started on time. So therefore, early diagnosis and prompt treatment is a key to success and prevent serious complication in our patient. So thank you so much for your patient hearing. So it's a sincere request to kindly like, subscribe and share to my YouTube channel, Patho with MK. Stay connected, stay updated. Thank you.